I am Rosie Emmons. I currently work at Health East. I did work at Mayo Clinic for 20 years and at Regents Hospital for 5, and I've been with Health East for about 15. So I've been around the block a few times and I've done a few of these RCAs. So that's why they asked me to come and help talk about them, to help other people understand how to do them and how to make them more comfortable and how to make them more effective for you. Every time I walk into one of our facilities and I hear that a major event happened, my heart just sinks. I feel very badly for the patient and the family, but I also feel very badly for the staff. The staff are going through a lot right now. They really put their heart into their work. We know that they come to work every day to do a good job and that they try very hard for things to go well for all their patients. But we also know that they're humans, and humans make mistakes. So when mistakes happen, we really need to try to understand what happened and why it happened. We really need to examine them hard, and we need to learn from them. We need to get away from that old school of trying to find out who did it and making sure that they're disciplined well so they don't do it again. We need to look at these things as a learning experience and try to understand why they're happening so that we can help other people prevent them from happening again. We need to look into them to determine where things went wrong, and rather than looking at who did what wrong. But how do we decide which mistakes to examine? Things happen every day, as I said. At Health East, we assemble a panel of experts. And we do that because, again, mistakes happen all the time. They're happening every day. So which one of these mistakes do we really need to put some focus on and some effort into truly examining? The panel of experts will apply the rules. They'll look at the adverse health event rules. They'll look at the Joint Commission Sentinel event rules. They'll look at other things that are going on, the major focuses in the organization. This panel of experts knows about what kinds of things are happening all over, so they'll know if there's a pattern or trend building that we really need to start looking into a little deeper. So we assemble this panel of experts because it really is an objective panel. We really want somebody that's going to objectively apply the rules and not just hard and fast say we're going to do it for everything or we're not going to do it for anything. So how does that panel make the decision whether or not to do an RCA? Well, we get a little help from the regulatory bodies. We have we're 27, now they're up to I think 32 never events that we have to report through the state of Minnesota. So we have all of those that we need to look at. We have the Joint Commission, they have their own list of events that we have to look at. And, excuse me. And we really want to look at, again, serious events that are happening within the organization. And again, the panel will know certain things. Certain people know of an event, but this panel will know of all the events that are happening in the organization. Some events are clear. They're spelled out fairly clearly by the Department of Health. They have clear definitions about what type of events you really need to report. Some of those have a little lack of clarity, but they have provided some clarification information for us. So that helps to guide us when we need to do an RCA. And if we need to report something, either to the Joint Commission or to the Department of Health, we really need to examine it closely. So we really need to do an RCA. So we really need to make sure that all of the events that we have to report, we have a thorough investigation with. NQF defined these events because they really firmly believe that these events should never happen to a patient when they come into one of our facilities. NQF, by the way, is the National Quality Forum. And so they have come up with a long list of events, and we've been borrowing from them, looking at certain events that would happen most frequently in our facilities. And so that's where our 32 never events have come up, and a lot of the Joint Commission events have come from the National Quality Forum. And again, they feel that these events should never ever happen within one of our facilities. The Joint Commission has come up with their own list. It's not quite as clear. And so we really try to apply our own definitions as to what they're looking for when they look at those kinds of things. It leaves a lot of room for interpretation. I don't know if all of you are required to report to the Joint Commission, but we do have to make sure that if one of the events happens, whether you report or whether you don't report, you do need to do an RCA. You need to do a thorough examination, because should they hear about it, they will come out and they will investigate. So whether you report it or not, if they hear about it, they're going to come out and they're going to do a thorough investigation of that event. So it's really important. Some of the events by the Joint Commission mirror the NQF or the Department of Health ones. For people who do report into the Joint Commission, they track all of the events, and should they see a pattern building, they will add it to the list. So their list will grow from time to time. So it's important that you go out to the Joint Commission website periodically, look at the list of what they're requiring, because it does change from time to time. But what happens if one of these events wasn't the MDH regulatory events or the Joint Commission events? What happens if an event happens and it doesn't quite meet that definition? Well, for one thing, you were lucky. Because these events, again, can happen at any time to any person. And we really don't want them to get to the point where they meet the definition. We really like to jump on top of theirs. There are many things that we're required to do every day. So why would we have to do something that's not required, such as an RCA for one that is not required? Because it's an opportunity to learn. Again, we really don't want to wait until it gets to the point where it becomes reportable. If we are finding some events happening that are very close, we really want to jump on it and get a handle on it and find out why are they happening. Because chances are it was just a stroke of luck that kept it from getting to that reportability piece. And we won't be so lucky next time. There are a lot of events that are called near misses or repeated problems or whatever you want to call them. Some people call them good catches. And these kind of things will tell you the same story. They will tell you a very interesting story about why events are happening. So it's really important to take a look at some of these and really dig in to try to understand why they're happening. Repeated medication errors or repeated falls. We had a medication error at one of our facilities where they were doing med reconciliation prior to surgery. And the nurse was taking down the history from the patient, getting all the list of medications that they're on. And the patient said, well, I'm on insulin. And they said, well, how much insulin are you taking? And the patient said 100 units of insulin. So the nurse was entering all this information in the computer and wrote that into the computer. As she got to the end of the whole list and the end of her interview, she realized that didn't make sense. So she went back and she said, let's go back to the insulin. Are you really taking 100 units, or what are you really taking? And the patient said, oh, no, it's U100 I'm taking, and I think it was 40 units or something else, something totally different. So the nurse went back in to change that. And while she was in the process of changing that, she had finished the interview, so she was getting ready to click out of it and to go on to something else. She was interrupted. And prior to her interruption, she didn't hit save. So she left the computer, it went back and defaulted back to her previous entry. So it went down to pharmacy as an order. The next day, the pharmacist caught it and said, this is not 100 units of insulin, we have an error here. So they checked it. So we did an RCA on it because it could have been really bad. The doctor ordered it and everything, but the pharmacist was able to catch it. And so we really took a look at that situation and tried to understand, do we blame the nurse, or do we look in to see what caused that error from happening? And we found that the computer system that we had at that time didn't have a reminder, an alert that comes up that says, do you want to save your work before you leave it? And had that come up, she would have saved it and remembered to do that. So we were able to build that kind of a system into that. We also, another example at a different hospital that I'm working with, we noticed that with our orthopedic surgeries, hips and knees and that we were having an increased number of falls prior to going home. And we thought, well, this is getting odd. We really didn't want that, especially now that we're reporting falls with injury. We really want to take a look at some of that information. So we decided to, and not one particular fall, but just decided after a fall, there were a series of falls on that same unit, that we were going to look at the whole process of the fall. So we sat down to do an RCA to look at that, and we realized that with patients for orthopedic surgery, we were moving them out quick, not keeping them in the hospital that long. We're encouraging them to get up and move around and walk a bit before they leave. But we really weren't assessing the readiness for them to be able to walk on their own. and really getting involved in to see what was the risk of fall for them, different, because they were getting ready to go home. So there was a risk of falls that they were assessing while they were in the hospital, but they weren't really looking at that as they were getting them ready to go. So then we started looking at what kind of information did we need to provide the patients, and did we need to change the way we do our assessments with these type of patients so that we make sure that they have the right message prior to getting up and moving around. So those are a couple examples. Another possibility is to look at events that happen between departments. I know one of our hospitals is a primary stroke center, and with that, and it's also primary PCI center as well, but with both of that, there's a lot of time crunches and timelines that have to be met because you're reporting all this into the Joint Commission or whoever you report to. And so the patient comes into the ER, there are things that are being done in the ER for each of these populations. It's under a timeline. The cath lab gets the patient at a certain period of time, everything gets done. When the timelines aren't being met, fingers get pointed. People start complaining the ER took too long to do this, or the ER took too long to take these tests, or the ER did this, or the cath lab wasn't ready when we wanted them to, or we tried to get the patient up to the cath lab, but nobody was up there to take the patient. There was a lot of excuses that come up. So rather than letting them point fingers and getting more animosity toward each other, we sit them down at the table and say, okay, look, let's talk about this. Let's look at the processes that we're dealing with, and let's try to understand where things are falling through the cracks. And when we sit them down at the table, all blame is removed. They sit down, they look at the processes. It's not the people, it's the processes that are issues right there. We had another problem with one of our hospitals sending patients to a different hospital for radiology procedures. And the same thing happened. We had patients that were either delayed in getting back, or there was, when they got back, there were complications that they weren't prepared for when they got back. And patients were becoming a little sicker, and they were needing to get back to the hospital, but they weren't being able to get back because they couldn't get the transportation. A lot of problems were arising. So there was an animosity building between the radiology department and this other hospital. So we sat them down at the table and said, okay, let's take a look at this. Where are things falling through the cracks? Where are you having problems? We walked through the processes and tried to identify where the gaps were. And we were able to come up with a great action plan that were able to help both sides so that all blame went away and they started working better together. So I think it's really important to take a look at some of the events that are happening in your facility, whether they're near misses, whether they're just conflicts between departments, to take a look at things. But you can't do an RCA every time something goes wrong. So how do you determine when is an RCA necessary and when is it not? One way is to use the safety assessment code that is, we borrowed it from the VA hospital. So it's a safety assessment code, and it's a tool that will help you prioritize events to help you determine when you need to do an RCA. However, I want to caution that this is a tool only, and if your gut tells you that you need to do an RCA, then do an RCA. If the hair on the back of your head stands up when you hear about an event, do the RCA. Don't try to question it. Use your best judgment. Your judgment won't let you down. The code is based on two dimensions. One of them is severity. So how serious was the event? How serious was it in actuality, or how serious could it have been? So taking a look at your severity, you need to try to base some scales to help you identify what is your severity scales. This is some examples that we have developed. The important thing here is to use the definitions consistently. So when you say something is catastrophic, that's your definition for all of those errors that happen that meet that definition. Don't try to fudge or move things around a little bit. Make sure that you're keeping the definitions consistent. The next dimension is how often does it happen at your facility? And each facility is a little different. Some of you are trauma centers, some of you are a small hospital relying on bigger hospitals for a lot of your procedures. So examine your facility and say how often this could happen at your facility. You put those two dimensions together and you come up with a score. 3 represents the highest severity, and that should require an RCA. But again, use your judgment. Use your judgment in determining whether or not an RCA is necessary. That won't get you wrong. If there's a lot of conflict going on, a lot of talk out there on the units, a lot of conflict between departments, sit them down and do an RCA. It doesn't take that long, and it will solve a lot of issues. Once you've decided to do an RCA, a certain flow of events should happen. This flow should be understood by everybody so that everybody knows what needs to be done and who needs to be notified. There should be no need to scramble when an error happens or when an event happens. It should be very clear to everybody, from the nurse taking care of the patient all the way to the supervisor to administration to your quality department. They all should know what needs to happen and when. This helps to keep it timely. And it also, because you really want to make sure that you get to the table as quickly as possible, because details can be forgotten. We all know that in very busy times, a lot of things are going on, things can get mixed up, things can get misconstrued, a lot of talk can go on, which also can distort the reality. You really need to make sure that you have it timely as possible. That's why a timeline is very helpful. The RCA process itself is not new. It's been around for a number of years in the industrial world, and we've adopted it into the healthcare world. What kinds of things, when you were out there doing RCAs, did you struggle with the most? What were some of your areas that you really had the most problems with? I think it's important to remember that as we're doing RCAs, it's processes and not people. So you really want to focus on the process and the system and what's going on that's causing people to make the error. There should be no pointing fingers or placing blame at all. And as a facilitator, that's going to be one of your primary responsibilities, is to prevent that from happening. There's no right way to do an RCA. And when I say that, it means that you as a facilitator have different skill levels, you have different comfort levels, you have different ways that you like to do things. So trying to set it up so that it's standard for everybody, I think, is a difficult thing to do. Because what might be good for me won't work for someone else. Some people like a lot of structure where they have everything all spelled out, they've got an agenda, they've got everything on paper, people are looking at things, people are reading things. You're walking through the steps one by one by one. Some people like to be a little bit more laid back and easygoing with it. It puts other people at ease, but it also is part of their technique, where you let the people tell the story. And it's the facilitator's responsibility to pull the details out of the story that you need to help you and to direct the work. So whatever way is most comfortable for you, that's what's going to be important, because you're going to need to set the tone for everybody else in the room. You need to reinforce that this is an opportunity to learn. So however that needs to happen, whatever kind of technique that you use, needs to reinforce that this is an opportunity to learn only. That we're not trying to look for problems here, or we're not trying to look for blame. Staff come to the table with a lot of emotions. There's a lot of things going on in their heads after an error. And then when you're asked to come to the root cause analysis, that sounds just horrible. And people get all anxious about it and all worried, and they're worried that their jobs are on the line. They're worried that they're going to get in trouble because of something that they did or they didn't do. And they're feeling horrible about what happened with the patient. So we need to put them at ease so they can talk about this, so we can really dig in and understand what happened so that we can correct it going forward. They're not going to do that if they're feeling defensive or they're feeling afraid. I've had people come to the table in tears, just in tears, feeling horrible about it, worried that they're going to lose their jobs. And it really does take a lot of technique to get them to calm down, just want to look at the facts. Well, right now, what we're going to do right now is look at what happened. We're going to look at the processes that you went through. I don't care who did what. I just want to know what happened and why did it happen. Where did things fall through the cracks? And so that you need to put them at ease. The investigation is theirs. They need to really do the investigation. I wasn't there. The manager oftentimes wasn't there. These staff were there when the event happened. They need to own this investigation. They need to talk about what's most important to them about why things happened. If they're involved, if they feel like they're able to get this off their chest, if they feel like this is something that's going to be beneficial for them, they're more likely to participate. They're more likely to be willing to look at changing some things, which is what they're going to have to do. Because change is going to happen in order for this event to not happen again. If you don't change something in your process, the event is going to keep happening. And so you really need to help them understand that we're going to get together, we're going to look at this, something will change, but you're going to guide that change. Then they're more willing to sit down and look at the table and really understand what happens. And the RCA is intended to answer many questions. What happened and why it happened. We really need to understand where things fell apart, where things fell through the cracks. Was it a system issue? Was it a communication issue? Was it a failure to plan or recognize? Where did things break down? It's really intended to look at and answer all those questions. And we really need to understand where all the barriers were. We need to help identify all the barriers from preventing the right outcome. We also need to respect their time. Now, when you talk about some of these things, you think, oh my God, this could go on for hours. Most of the RCAs that I do take an hour. I ask people to come to the table to sit down and talk for an hour, whether it's a reportable event, whether it's a near miss. Most of the time, I can get staff to leave their unit not only physically, but emotionally and mentally, and come to the table if I say it's going to take an hour. If I say it's going to take more than that, I get resistance, or I'll see in the meeting, people will start to drift off. So it's really important to make sure that you keep this timely, that you keep this respectfully for their time as well. They're already going through enough emotion. We don't need to drag them into a long, dragged out process. We're not trying to solve world hunger or try to answer all the issues, but we really need to understand the details that happened when we weren't there, and that's what they can tell us. Again, they lose attention after an hour as well. So they're thinking about stuff that they've got to do. Somebody's watching their patient, but the work isn't getting done. They're going to have to go back to that unit. They're going to have to pick up their work and make up the time that they were lost. So they really will be willing to work with you for an hour, but longer than that, it's harder to get them to come to the table. The initial step is to understand the sequence of events. So what happened, and looking at what happened at what point in time, trying to understand and break down all the times with things were going wrong. And sometimes this could be done outside the environment, outside the RCA, and then you bring it to the table and confirm it there so that everybody agrees on it. The important thing is everybody has to agree on the sequence of events. So you really need to understand what happened and what point in time. And sometimes if it's really controversial, you're going to need to do it during the RCA. You may have a structure or a framework of it, but you really need to spend some time making sure that everybody agrees this is what happened and when it happened. Sometimes it's important to review literature. If you're working along and you want to know right before you go into that RCA, are we keeping up with the latest trends? Are we keeping up with the latest techniques? Is there a better way to do these things? And or should we be doing something different? Is there different techniques, different equipment out there that we should be using, different medications that should be a part of our processes? Have that information available, because somebody's going to ask the question, well, if we had better tools, then you can either say, well, there are better tools out there, we can look into that, or say, you know, I did this literature search, we have the latest technology. So how do we determine which staff should participate? This is a question I get oftentimes at these RCA meetings. Who should be at the table? Well, the people who are directly involved with the event, that's kind of a given. They really need to be there. There are certain key people, the patient's nurse that was there, the patient was caring for, the nurse that was caring for that patient, the charge nurse, anybody who touched that patient or had responsibility for that patient, they should be at the table. We need to make sure they're there at the table. This is a multidisciplinary process, so if a physician is involved, they have to come to the table. They have carried a role in this event. They have been a part of this error. We need to make sure they're at the table to talk about their part of it. That's not always an easy thing, I know. I have had difficulties with physicians coming to the table as well. Or I've had physicians that come in, you know what, I did the error, it's all my fault, I'll take full responsibility. And I have to remind them, we're not looking for blame, not looking to find somebody who to put blame or pin this on. All I want to know is what happened. You played a role, you're going to have to share in that role. You need to know what the other roles were that happened around you. So if it's a surgeon, he needs to know what was the scrub nurse doing at the time, what was the circulating nurse doing at the time, what was anesthesia doing at the time. If it's a physician on the floor, what were the other nurses? What information were the other nurses needing that you didn't provide? Were you communicated to? Were you communicated effectively to? So you need to work with them, and sometimes it takes me talking to the medical director saying, having a little problem with Dr. So-and-so, can you give me a little hand here? Then he will call up the physician and say, you know what, you need to be at the table and talk to them about coming. Doesn't mean that they're going to come to the table happy and willing. They may come to the table kind of irritated and saying, you know what, I've got patients to see, you're taking up my time. Say, I've only got an hour, we're only going to do an hour here, but you need to be here for this hour because you are a very key person that needs to be here. We need to think about what other departments may be involved. Was it just your floor? Was it something that happened in surgery and then carried over to your floor? Was it something that happened in radiology but nursing staff up on the floor knew about this? Who all was infected before and after the event? Who could have contributed to the error? So it's really important to look at that. Leaders should be at the table. They're responsible ultimately. They need to be there to hear where things are falling apart so that they can help you bust the barriers. They need to understand the struggles that you're having. They can't get that from me saying, well, you know what, they're having a problem with this process. You need to look into it. They need to hear it from the people who are struggling and why they're struggling and what kinds of struggles are happening. Sometimes you need experts to come to the table to help bring clarity and a different type of understanding. So bringing in your walk nurses, even if they weren't involved with the pressure ulcers or sores that were developing for the patient, they have a different way of looking at things that can help bring clarity to the situation. Sometimes they've got CNSs, nurses, special nurses out there. We have CNSs for our geriatric population. We have CNSs who really focus a lot on falls or skin issues. Bringing them to the table to help, again, looking at it from a different perspective. They may have not have been there at the time of the event, but they will have a different perspective and different understanding of what could or couldn't happen at that time. Bringing in informatics, if it's an issue with your medical record, electronic medical record. Bringing informatics to the problem. We had problems with physicians putting in orders, and somehow, we don't know for sure, the patient got switched, so the doctor would end up putting an order that he intended for one patient on another patient. And he swore up and down that the name of the patient that he was putting it in was right there, but it didn't get to that patient. So somehow in that process, there was an issue that we were having problems with. And again, we're dealing with people telling us what was going on. So bringing in the informatics and saying, okay, when you put an order in and you do this, this is what happens. And if you need to do this, so if your medical record is complicated, which our currently is, but we're switching to a different one, then you're going to have to go through a lot more steps than if you had a smoother process. And you know docs, when they write orders, they write them out, it was very easy. They thought they could write it out and it was done. They put it into the electronic medical record and then they have to choose orders and then they have to choose such and such a thing. An alert may pop up and they don't know what to do with that, and so they have to figure out what to do with that. And doctors don't like that, too many steps. They want 1 or 2 clicks and they're done. With writing an order, it was easy, but it was easy for them, but not for us because we couldn't read the orders half the time. So bringing in the informatics to help you through the EHR issues will help, and they can certainly sit at the table and hear all the problems. They may be able to hear with all the things that we're struggling with and go back to the people that are setting up the computer systems and create a fix that will make it smoother for you. They're the only ones that can help you with that. We had a problem with patients had put a tube feeding in during surgery. They had to put a feeding tube down. And when they got to the floor nurses weren't sure was this a J tube or a G tube. And so as you know with that, you have to do some checking of residuals. And so some nurses would check residuals and some wouldn't. That was all dependent. In the record, it was written differently. The surgeon had written at one point J tube, one point G tube. So what is it? Nobody really knew what it was. And so it was really confusing. And so we pulled an RCA together because the patient eventually aspirated and had some problems. And we really need to understand what happened here. Where did things go wrong that we had this? Why didn't they check for residuals? Why didn't things get checked earlier so that this could have been avoided? And we found out that nobody knew for sure what type of tube it was. So then we asked the question, why did that happen? How did that happen? So we looked back into surgery and found out that it was documented different ways in there and documented different ways on the floor. So no wonder nurses didn't know. They didn't have a clue. So they set up an action plan looking at all of that, but they forgot to bring in surgery. And surgery is key because that's where it was placed. They're the ones that know at the time where the feeding tube went, how far it went down. So they put up this action plan that said that all the tubes are going to, and as you know, the tubes, once they're in, you don't know if it's a J or a G. You can't tell the difference. And so they put up this action plan where they were going to have surgery, mark all the tubes with a piece of tape saying this is a G tube or a J tube. Well, that's just fine and dandy. Sounds like a good idea, except they didn't bring in surgery. So they were asking surgery to do something without surgery contributing to the conversation. And so there was another little conflict. We had to come back to the table, talk about it again with surgery at the table. And so it's really important to think ahead. Who needs to be at the table? Who could have been involved in this? We found all sorts of issues. Again, it's issues documenting in surgery, the tubes looking alike. And some solutions are going to be put out there and recommended when the people who are involved in carrying out or implementing those solutions aren't at the table to help talk about it. And it's not only is that not fair, but you have no authority to tell them what to do. And you don't know if that's going to infect their processes. Is that going to make it more difficult for them? So they're going to be asked to do extra steps when they weren't at the table to really investigate it. We need to create a safe environment for them to share information. Anything that's in the medical record is discoverable. It's up for grabs. It can be used in court. It can be used by the Department of Health. It can be used by anybody they need to do their investigation, any regulatory body. But your thoughts, your opinions, all the discussion that happens in the RCA is totally protected under the Minnesota statutes. So you need to let people know that. You need to enforce the fact that anything you say in here, all your thoughts, all your ideas, all your opinions, put them on the table. We need to hear about them. Don't hold back, because that's what's key. That's what's going to tell us where things broke down. It's not what I see in the medical record. I could do my own RCA if all I was going to do was clean through the medical record. But there's a lot of things that happen outside the medical record that don't get documented. And it's that information that I want to know. I want to know, was the unit so busy that you didn't see that patient come back from surgery? Or you didn't hear that patient fall? What was going on in your mind? How busy was your staff? What kinds of work were you doing? What processes were you trying to do that this fell apart? All of that information is totally protected. You as a facilitator need to help the staff feel comfortable. So not only knowing that it's a protected environment, but knowing that there's no judgment based on them for what they say. So it's really important for you to stay neutral. Sometimes that's not that easy to do, because I'll hear about events and I'm going, what were they thinking? As I'm listening to them do different things or hearing the details from the clinical director, I'm thinking, where did that come from? Why did they do that? But I need to put that all aside because I don't know why they did it. That's what I'm going to find out in the RCA. So it's really important to make sure that you as an RCA or facilitator are neutral, that you're not going to be holding judgment on anybody. You need to make sure that you keep it focused on the processes and not on the individuals. And again, that can be hard sometimes because when you get into RCAs that are particularly emotional, people are going to start pointing fingers. People are going to say, well, she should have done this, or he should have done this, or had the doctor told me that, I wouldn't have done this. But you need to keep it back on the processes and saying, okay, let's take a look at why they didn't do that. Let's take a look at why the doctor didn't talk to you about this, and keep it back on the processes. We want to make sure that everybody has a chance to share. If they're at the table, they were meant to be there for a reason. So everybody needs to be able to speak up and say their piece, whether somebody else has done all the talking or not. If they're at the table, they have a role, a key role in the event. We need to understand what that role was. Some people are really good talkers, and they like to take charge and talk and talk and talk, and they know it. They've already done their own investigation, and they can share everything that they've learned. Fine, that's good. That's good and dandy. However, I make sure that everybody has a chance to talk. And for those of you who sit back and don't say anything because, well, it's been said, and I really don't know that I have anything else to add, I'll call them and say, okay, what is your view on this? And ask them to start participating. And initially they may start out a little timid and say, well, you know, everybody said this already. And say, well, yeah, but tell me what you think. What is your thoughts about this? Then they're going to come out and then they're going to say it. So you need to coax them a little bit and give them permission to talk. Because again, some people like to carry on. And we want to make sure that the information that we collect is going to direct the action plan. So we really want to make sure that all the information that we need is out there. So to be thorough, we really need to address all the key elements for each RCA. Sometimes that can look a little overwhelming, and sometimes you look through the events and say, well, I really don't think it had anything to do with equipment, so we won't address that piece of it, or I'm not sure staffing was an issue, they were going by the grid. If you don't ask the question, if you don't talk to them about it and say, well, what happened about staffing? How was your staffing? Even though you know that they were on grid, you won't know that maybe grid wasn't appropriate for this situation, even though that's what they're supposed to be doing. So it's really important to ask the key questions of all of these things. Don't leave them out because you don't think it applies. If you don't ask, you won't know. You won't make sure that it's addressed. It may not always be clear if it's a contributing factor or not, so you really do need to ask the question. Again, feeding tubes not being marked, where was the issue there? So it wasn't an equipment issue. You wouldn't have thought so if you would have just focused on the nurse not checking the residual. You wouldn't have realized that the feeding tube was not clear to anybody, whether it was physically not clear because it looked the same thing as the J tube, or the documentation was unclear. So it's really important. You don't jump to human error. There are certain triage questions that are available to help you, and they're developed to help you make sure that you dig deep enough, that you get thorough enough. These triage questions are in your packets, in your binders there, so that you have all the information. These are the categories, and in the binder, it'll have questions that go with each of the categories. Now again, as a facilitator, you can either pull this out and ask the questions during the RCA, whichever is comfortable for you, or as you get rolling on RCAs and doing enough of them, you're going to know what the categories are, and you're going to ask the questions without having to go through it one by one by one. Your job is to make sure all the questions been asked, whether it's in that certain order, or whether you capture the information, and that the information that didn't get discussed, you go back and ask the question then, to making sure that everything gets addressed. So it's kind of up to you, whatever you're most comfortable with. Joint Commission has what they call their minimum scope for root cause analysis. Across the top are the different types of events that they would recommend. Down the side are their triage questions, their categories for triage questions. And so if you look at this, if you think that this is going to be a sentinel event that might be something the Joint Commission will be looking into, you might want to check the minimum scope before you go out and do the RCA to make sure all the categories with the X's have been addressed during your RCA, because they will look at that, believe me. I've been a part of those investigations, and they do like to look at that. These are just recommendations for different categories. They're very similar, but they're a little bit more detailed in the Joint Commission piece. Documentation needs to be thorough. The documentation that is done for the RCA is the only documentation of that discussion. It is that protected. You can't be sharing that with everybody else. You can't be handing that out and working with that. You can't just let anybody do the documentation, because you as a facilitator need to make sure everything has been captured that needs to be captured. You as a facilitator need to make sure that all the information that was shared with you in that RCA has been written down. All the triage questions, all of the categories by the Joint Commission have been addressed that have to be addressed. All the regulatory bodies are going to be looking at this at your RCA if they are called in for an investigation. They're going to come in, they're going to look at thoroughness. They're not going to look at the details of it unless it's not considered a thorough investigation. But they're going to look at the thoroughness of your investigation to see, did you look at everything that you were supposed to look at? Did you drill deep enough? So looking at those triage questions and those Joint Commission minimum scope questions is really important to make sure that you have addressed all the area. It's also nice because should the case go to court, oftentimes it's not going to happen within that year, within the next year, probably not within the next year. They can go up to 7 years. And by that time, staff that are involved in the event have some memory, but they don't have a lot. So they don't have a lot of memory. So they can then come back to you and review the RCA and refresh their memories. So it's really important to have a thorough documentation of what the event happened. You also want to look to see what's being trended out there. What worked and what didn't work? What kind of contributing factors? If we've done, say, 7 RCAs on falls, what were the contributing factors? Are there any trends there? Are there any similarities between the RCAs? And if so, why do they continue to happen? What does the action plan look like? Has it been a thorough action plan? Did we address the RCA root causes thoroughly enough? So looking at the documentation and going back and understanding what things were talked about, maybe at the time it felt like it was pretty thorough. But if things keep happening, you may have to go back and relook at some of that. In summary, with this, the RCA investigation should include all the possible contributing factors. You're sitting at the table with all these people that you felt are key people and important people. You need to make sure that all the questions have been answered, that it's been as thorough as possible. All of the contributing factors have been addressed. You look at the analysis of all of the key events. Why did they happen? What's going on here? What went on? You want to make sure that you've asked the question, why enough? You want to make sure that you've drilled down as far as possible. Out in Washington, there's a memorial. There's a lot of memorials out in Washington, but there's a particular memorial, I think it's the Jefferson Memorial, that is a big reflecting pond out in front of it. And the Jefferson Memorial is very popular. A lot of tourists come there. A lot of tourists like to view that and be a part of that. Well, they noticed that it was starting to erode. And so they were a little concerned about the erosion pieces. And so they had a team of experts that were gathered together, people that park board and all that were gathered together to go out and really take a look at the Washington Memorial and understand, why is this eroding? So when they get out there, there's a gentleman out there with a big bucket and he's scrubbing off the memorial. And of course, right away, someone thinks it's the soap. So they go up to this gentleman and they say, what kind of soap are you using and why are you washing with that kind of soap? And he says, I'm using the mildest soap possible because I have to wash this down every single day. And they said, really? Well, why do you have to wash it down every single day? And he said, well, it's because of the pigeons. And you know, with pigeons, you get pigeon poop, right? Tons and tons of pigeons flock to the Jefferson Memorial. They must like it too. And so they're there all the time. And of course, with the pigeons, all this extra poop is there. So he's got to scrub it down because if he doesn't, nobody's going to want to go there. It's going to be pretty rank after a little bit here. So they really have to scrub it down. So that's what he said, because of all the pigeons. So what do you think somebody from the team said? Kill the pigeons, exactly. But a very wise quality consultant said, why are there so many pigeons? And the gentleman said, well, it's because of all the spiders. The spiders are just collect along the top of the memorial and along the sides there all the time. And the pigeons just love it. They feast on the spiders, and it's really easy for them. They don't have to go out and search for food. There's tons and tons of spiders there. So what do they say? Kill the spiders, exactly. Quality consultant wasn't done, hadn't dug down deep enough yet and said, why do you have so many spiders? And the guy said, well, it's because of all the midges. Midges are little tiny microscopic insects that like to be in reflecting bodies of water, reflecting pools, and the reedy marsh around there. That's where they nest and that's where they home. And they come out at night during the day and into the evening, and they feed and they're out busy doing stuff, and they've got to get back to their home or their little marshy area before dark, or for some reason they can't see and they can't get back, and then they die. And a lot of them have been dying outside, so the spiders are happy and will go out there and feast on the little midges. So they determined that because of the midges out there, that they weren't being able to get back. So they decided at that point to turn the lights on an hour before sundown. So it would give the midges a little bit more opportunity to get back there because things were starting to get dark. So once they did that, they had less midges problems. Less midges, less spiders, less pigeons, less pigeon poop. And they didn't have to clean it but once a month. So all they did was drill down why, and didn't stop with killing the pigeons. So it was really important to ask those questions deep enough. After gathering all the information and the facts, you have a lot of information there. A lot of the things that you've gathered, because you've intentionally gathered a lot of detail. You've intentionally looked at a lot of information, all the different categories. You've got a lot of things going on in front of you on the paper, and it can look kind of overwhelming. What do you do with all of that? How do you pull it all together? You as a facilitator need to do that, because you're not going to expect them at the table to do that. They've been doing all the work up till now. So it's really important for you to make sure that you figure out a way to get all that information pulled together. We need to pull out all the key issues. And what I usually ask my teams after they're done talking, or when I feel that they've talked out enough, because sometimes you got to cut it off. You start hearing the same old thing, the same stories and that. It's time now to just start looking at pulling it all together. And I say, okay, now after hearing everything that people have said, what do you think are the main issues? What do you think are the main contributing factors that contributed to this event? And so then they start thinking, and of course they think about the pieces that are most important to them. And they'll start coming up with different things that they feel are main contributing factors. And so it's really important for you to try to capture all that information and maybe put things together, maybe kind of combine some information, whatever you need to do to be able to come up with the main root causes. And everybody's got to agree on the main root causes. And so it's really kind of pulling them all to do that. You need to do that, so it really helps them stay focused. And the root cause statement will help you to do that. We're really trying to understand what contributed, why something happened and why it went wrong. What was the cause and effect relationship? So this was a contributing factor, how did it affect the outcome? So we're looking at all of those pieces. It really helps to stay focused on why it happened, and it helps to direct the action plan. So it's really important as you're pulling out the root causes and they're telling you that, to ask them, okay, how did that affect you? This is what you think. So you think that the person not having the J-tube labeled correctly was the contributing factor. How did that make a difference? So asking those questions, making sure that you understand the whole piece. Don't just jump right into actions, which we all have a tendency to do. Especially in healthcare, we start hearing about problem, and what do? I've got a solution. I know exactly what's going to fix that problem. We really need to understand what were the root causes, what were the basic underlying issues, so that if we address these, the chances of that error happening again won't happen again, are very small. We also want to don't jump to human error right away. Human error is often not the contributing issue or the main factor. It's a symptom of deeper issues. If you've come up with the fact that this is a human error, that person did wrong, you need to dig a little deeper and find out why. Why did they do that? Why did they not do that? Don't just jump to human error. We may need to ask why, again, to find out why. So if somebody comes up, well, she didn't check on that patient, that's why he fell. Say, okay, why didn't she check on that patient? So looking again, back to processes. What were the processes that were either there or not there that prevented her from checking on that patient? But anyway, so you want to choose really carefully the events that are going on out here with the root causes. You really want to make sure that you pulled out that information very carefully and you've stuck to the event. Because I don't know about you, but in some of mine, they've gone a little tangential. They're starting to correct things that didn't even happen and don't relate to this event. Bring them back to this event and say, you know what, that's a problem, we can address it another time, but right now we're talking about this fall. And we really need to understand what happened. and back to the fall. So you're going to have to be bringing them back. The 5 rules of causation will help you develop your root cause statements. They will help you direct where things need to go. And believe me, once you got the root cause statements down, your action plan falls right in place. So it's really important to spend a little bit of time pulling out those root cause issues and making sure that you've developed that cause and effect relationship so that you know if you address this, it's going to affect this problem. It's not going to affect something that didn't ever happen or have anything to do with this issue. We're going to fix this problem. You want to make sure that the root cause statements are not negative, that you're really staying with positive information here. Because people don't really want to react to something that's negative. They want to say, well, it was poorly done, or that the incompetent nurse, or any of those kinds of things. You really want to stick with the positivity of it. You want to make sure that there are, as a preceding cause, so if you get again to a human factor, you need to ask why one more time. Same thing with the policies and procedures. Policies and procedures don't cause you to have errors. The fact that they're not effective will cause you to have errors. But we need to understand why are they not effective? What is wrong with that policy? So if they say, well, we really didn't have a very good policy for falls prevention, you have to ask why again. Why didn't you? What's lacking in your policy that you don't have? And so have that. There have been questions that came to me about what happens if you're going through an event and you don't have a root cause. You've come up with nothing. There are really no issues. Everybody did everything they could. The error just happened. You know, mistakes happen. I buy that if you're looking for blame. If you're not looking for blame, but if you're looking to determine where things fell apart, you're always going to have a root cause. You're not looking to find somebody to pin this on. You're looking to find where things broke down. If you have a reportable event, if you've got something bad that happened to somebody, whether it's reportable or not, something fell apart. That's what you want to understand. Because if you don't have a root cause and you go ahead and build an action plan, what are you building it on? You don't really know, you're guessing. You're trying to improve something that you've already said is okay. So you really need to make sure that this is your best guess as to what could have happened. Things aren't perfect. You don't need to be totally accurate and say, okay, I know exactly that this is what the root cause was. We can say, this is what we believe happened, that the nurse didn't know this. Or we can say that the policy wasn't as complete as it should be. You know, and these are kinds of things that happened. But you really need to understand and use these root cause issues. The issues that you've identified are the issues that contributed to the error as part of your root cause statements to help you guide that. So you ask the questions, okay, what made this difficult for you? What made it difficult for you to put the name band on the person? What made it difficult for you to check on that patient? That was what your root cause would be. Looking about what could be done differently. Okay, so you did everything by the book. Well, maybe the book wasn't accurate. Maybe the book is outdated. Maybe the book no longer works for you because you've had a change in technology. You've had a change in processes and systems. Things have been built around this, and this has been kind of makeshift in there, or grandfathered in. So now it's not working any longer. What could be done differently? And what prevented you from going that next step? What prevented you from doing this piece? That's the information that you want to find out. That's what you're going to be your contributing factor. So, for instance, we could have left it that with the information on the computer that the computer just didn't save. Well, that's really not my problem. That's the computer's problem. But again, we're not looking for blame. We're looking to say, what happened? Why did it happen? What can we do differently? So we then fixed that computer system to save so that that nurse didn't have to remember to do that it automatically saved things. We always want to make sure that we can find something to improve. So the fall that we talked about, did we talk about a fall? I don't remember talking about the fall now. The medication error for sure. Oh yeah, the falls within the ortho unit. The falls, so we looked at those falls and found out that there was conflicting messages. So the root cause statement that we had was conflicting messages to the patient, inadequate preparation resulted in the patient falling. So again, we're not blaming anybody on this. It's just saying that we just didn't do a very good job in these areas, so this is where we're going to need to look differently. And the same thing with the computer issue with the medication error. The computer failure to save the information led to erroneous medication info, resulting in wrong meds ordered, the wrong dose ordered. Not blaming anybody, but we're really focusing in on what we felt were the contributing factors for those two errors. Here's some examples of the root cause analysis tool that we use currently at Health East. If you look at it, it's kind of reminiscent of the Joint Commission because we borrowed that too. Looks through all the different areas, the contributing factors. It's a Word document that we use. So all these boxes can be expanded to put in as much information as you need. You can also add your own questions here. If these questions are appropriate, you can add different questions, depending upon the types of events you have, depending upon what kind of errors you're working with.